Sir, we are live. We can start now. Thank you.
Good evening. Today I'm presenting case for Thursday Clinic. 1 year, 8-month boy, third by birth order, born out of third degree consanguineous marriage, Muslim by religion, Khan by community, hailing from Uttar Pradesh, residing in Dharvi, brought by parents with complaints of tightening of upper limb and lower limb since age of 5 months, and history of loss of attained developmental milestones since age of 5 months, and decreased oral intake since past 5 days. Since there is significant developmental history, I would like to start with birth and developmental history. Antenatal history, age of conception 28 years. It was a registered case. A regular antenatal checkup was taken. No history of fever during first trimester of pregnancy. No history of gestational diabetes mellitus, gestational hypertension during pregnancy. 5-2 scan, antenatal scans were done, was told to be normal. There is history of one intrauterine death in previous pregnancy. Natal history, preterm LSCS in view of query oligohydramnios. Baby cried immediately after birth. Birth weight of 1.6 kg. There is history of an ICU stay for a duration of 2 days for preterm care. There is also history of neonatal jaundice on day of life 4, and phototherapy was given for a duration of 4 days. There is no history of neonatal seizure or encephalopathy. Child was exclusively breastfed for a duration of 6 months. Child was apparently normal since the till age of 3 months. Thereafter, child was not able to hold head and was not able to reach for objects. This is at the age of 4 months. At 5 months of age, mother also noticed that child started having intermittent tightness of upper limb and lower limb, which was insidious in onset, aggravated while crying, and decreased during sleeping. Initially, it was around 6 to 7 episodes per day, each lasting for 5 to 10 seconds, which was also associated with difficulty in feeding in the form of taking feed for a duration of 30 minutes to 1 hour. Since last 4 days, there is also history of tightness of upper limb and lower limb, which has increased to around 50 times a day, lasting for around 10 to 15 seconds, disturbing the sleep. Since 5 months of age, mother has also noticed that there was a loss of head control and by distress reach, followed by loss of social smile at 8 months of age, which didn't improve with time. For these complaints, child was shown to doctor and was given some drugs which relieved some tightness, and also was advised for investigations further. There is also a history of generalized tightening. Mother also complains that there is difficulty in changing diapers since 1 year of age, which has decreased after exercises. There is no history of seizures or cranial nerve involvement, hearing or vision impairment. No history of precipitating factor like fever, vomiting or loose stools, or loss of consciousness or head trauma. There is no history of abnormal body odor. Child is immunized till date. Developmental history, gross motor and fine motor. At 4 months of age, child had head control and bidextrous approach. At 5 months of age, child had lost head control and bidextrous approach. Child at present opens hands spontaneously. Developmental age around 3 months and developmental quotient of 15%. Has lost social smile at the 5 months, which was present till 2 months. At present, child doesn't recognize his mother also. Language at present, cooing present, developmental age of 3 months and developmental quotient of 5%. Impression, global developmental disorder. Social, more than language, more than motor. Diet history, consumes around 700 calories and 13 grams of protein, deficit of 300 kilocalories and 3.5 gram protein. Family history wise, third degree consanguineous marriage. There is a history of similar complaints in the elder sibling. That is currently child is 7 years old. The child also had complaints of tightening of upper limb and lower limb since age of 5 months, and also a history of delayed developmental. Child was shown to hospital and was advised for exercises. Child is currently bedridden and dependent for all activities of daily living. Summary.
Go back. Come to the birth history, then because there's a lot of irregularities in the history. Come, you can come here. Leave that. That won't go in the system. Where's your this? Okay, so your chief complaints were actually loss of developmental milestones from 5 months away, for which you need to be very, very clear that you are absolutely normal till 4 months or 4.5 months of age. So I was not very clear on that from your history. So we'll go into that deeper again. Let's start from this birth history now. So you said history of intrauterine death in previous pregnancy. So this is which conception?
Third.
So one living child, one death, and this is the third conception. Okay. Now, a preterm LSCS, so preterm at what gestation? 35 weeks of gestation. Okay, so what is your comment on that first thing? Is 35 weeks of gestation, preterm and birth weight 1.6 kg? Ask for this so that your voice goes into the system.
Very low birth weight.
So what does it mean?
Very low birth weight, but child cried immediately after birth.
No, very low birth weight means, is it IUGR or it's not IUGR?
Not IUGR.
Why not IUGR?
Intrauterine growth rate. It's not IUGR only.
What I mean is that if it is a 35-week delivery, what birth weight do you expect?
Low birth weight. It's low birth weight. You can.
What normal birth weight do you expect at 35 weeks?
Appropriate for this. 2 to 2.5. 2 to 2.5 which.
Not 2, even 2.5. No, why 2? So see, 1.6 is pretty low for that. So first thing you have to make out is that this is IUGR. Now, neonatal jaundice on day of life 4. So by then and initially stay for 2 days. So was the baby out of hospital or in hospital on day 4?
After 2 days, child was out of hospital, and again day of life 4, child came back.
Okay. So in a premature IUGR baby, physiological jaundice appears earlier than normal or later than normal? So here it's appeared later than normal and then required phototherapy for 4 days. So these are things which are a little inconsistent, I thought. Sir. Okay. Fine. Then share anything on that. How can we?
The only other thing that we would want to point out is when there is SGA, you have things other than prematurity also which may be contributing to not gaining weight till the time the child was born. So it's just not the preterm baby, but you have a preterm with SGA. So then we can think about what are the other stressors or what are the other events which could or could not have occurred, which has affected the baby's growth till 35 weeks.
I think whenever there is a problem, we are not sure whether it started because of some perinatal or immediate postnatal period or a little later. And I think the birth history, you try to get more details. You have said no history of encephalopathy. What do you mean by that?
Irritability or convulsion. Irritability in the child, convulsion.
Anyway, we have discussed this here. What do you mean by no history of encephalopathy? It means baby cried immediately. Okay, lustily, got onto the breast, sucked vigorously. For 15-20 minutes, the baby was awake. Thereafter, the baby slept. Is a normal behavior of a normally born baby. Unless we have all those details, we won't know. And to that extent, we are a bit uncertain about the weight. Then the jaundice, just 2 days of phototherapy and discharge again. Everything looks up. Of course, you have got a history a year later, and that may not be very reliable. It's not your fault. But you could have asked something more again. Are you sure? How long did? Again, this baby stays only for 2 days, getting discharged, coming back again, another 2 days. Looks very unusual, right? Probably all that we mean is the baby was not brain damaged in the first 4 months. And that is what we wanted to. But we wanted to be sure whether there were some subtle findings that suggest that the whole story started little early, right?
See, the whole birth history and the subsequent things could well have led to similar complaints even due to the perinatal insult. So it is very important to, what I'm trying to say is, if you have a nice full-term normal delivery, 3 kg weight, all normal, and then at 5 months tightening versus a preterm baby who has gone through jaundice and tightening at 4-5 months, this tightening could well be related to that perinatal event as well. So you have to be extremely sure that for the first 3-4 months this baby was normal. So here you have written that 3 months baby was able to hold head. So can you talk more about the first 3 months, as in social smile, following the mother, looking around the house, all this history? Did you try and did you get it?
Like till 3 months, child like social smile was present, and eye to eye contact the child was making with the mother, and bi-dexterous wise, the mother tells like the child used to have hold the hands tightly, and when used to like pull, used to with grip used to come up. This much mother told.
So this is a little, again, I feel this is not normal, as in holding the hands tightly at that age such that you can actually bring the child up
5
is on the pathological side. What age are you talking of?
This one was at 5 months. Child was able to hold things, and like so smile was also attained from 2 months of age.
Okay.
I think we have a preterm, and also it's probably an SGA. Now, when you have this combination, what kind of problems are you anticipating that you make sure that they never existed? Okay, the baby cried immediately, maybe there was no problem intranatally, but what happened thereafter? So, would you say that what are the problems of a preterm and also SGA baby at birth? Come on, give it.
So what sir is asking is that for a moment, if we are saying that these problems are related to the perinatal problem, so preterm SGA with jaundice, what kind of motor abnormalities would you expect in this child?
If in case of neonatal jaundice, if it had not been intervened at the right time, could lead to changes in basal ganglia. Insult could occur, and that can lead to extrapyramidal symptoms.
So you would
dystonia.
expect spasticity and dystonia.
Dystonia.
Okay, which limbs predominantly?
Upper limb.
Why upper limbs? Suppose a preterm baby were to get cerebral palsy, which type of cerebral palsy are they prone to?
Spastic quadriplegic CP.
Okay, why quadriplegic?
Quadriplegic, more more of a focal lesion. Middle part of spinal cord gets affected, and more proximal parts of corticospinal tract get affected.
And who gets spastic diplegia? When do you get spastic diplegia? Which parts are affected? Pyramidal tracts are lower down, but yeah, but which areas are affected in the brain? Huh? So periventricular damage is what gives rise to spastic diplegia, no? Right?
Agreed that there was something to be known about the immediate neonatal, etc. I have a different view. Whatever the lag of history may be there, we must be able to correlate the degree of damage with the degree of subsequent progress. Now, even if there has not been a very good elucidation of the history in the neonatal birth, the problems were not gross. The problems were subtle or mild. They cannot explain the further progress of the disease. So while we will make an effort, we may not be able to lay too much of emphasis on what happened in the neonatal period, because whatever happened was not consistent with what the progress of the baby was. Progress has been severe, progressive, and none of the so-called relatively subtle damage can explain that. So while we'll make an effort to get a better history, this history is not consistent. I mean, this history is adequate to explain or rule out a prenatal. I can say that significant prenatal problem did not exist, which can explain the further progress of the disease.
Perinatal. Now, okay, what about these intermittent tightness of the limbs? What do you think this is? Okay, so on history, how do you separate out dystonia from a seizure?
Like on stimulus, the tightening episodes increases, while in sleeping it decreases. In case of seizures, it's not related to stimulus or decreasing while sleeping, and there is like no PID thing.
No?
PID. Convulsion usually like PID. Then lasting for seconds. In seizures, it might be like minutes.
This was affecting all limbs
All upper limb and lower limb.
at the same time?
At the same time.
Okay. What is the difficulty in feeding? What do you think that is?
That is because of dystonia part only. Mother was not able to feed. Long period of time, 30 minutes to 1 hour. And also, there was like increase spasticity of all the limbs also. Holding and feeding.
Okay. And then you feel these were all definitely achieved: head control, bidextrous reach, and social smile,
Yeah.
which you are saying they are now lost.
Now lost because mother has noticed in first child she has noticed same thing. So in second child she was more cautious. So she has noticed it properly.
So antenatally, they were not investigated in view of the first child's history.
No, sir. After like our first child के बाद actually it was investigated, but second child eventually she conceived. उसके बाद ही parents का they had like investigated.
I think we are discussing what we would have thought of right to begin with. Okay, subsequently, we have a loss of milestones. So there is no question. There was no damage which we could consider static. And now we are straight away on a progressive disorder. The reason to talk about like this is, for example, a Down syndrome could have some resuscitation required at birth. So the history would say, oh, child was a little breathless or was not feeding, required oxygen, required resuscitation, and then subsequently. Then in that case, we had to consider, correlate what extent of damage so-called and what is the outcome. That's what he was mentioning about. Here, there is no question. We've discussed this because this was a preterm and SGA. And therefore, you could have had a hypoglycemia, you could have had polycythemia, you could have, of course, jaundice, but jaundice would have gone on worsening, not discharge, etc. So now we are certainly a progressive disorder. Okay, white matter or gray matter?
Based on symptoms, cognition is affected at present, and this dystonia part mainly goes towards basal ganglia is affected. फिर बाद में one thing is against is like history of like seizures का अभी तक history नहीं है, तो it is going against gray matter. Eventually, like motor disturbances are also there, so white matter is also included eventually.
So when eventually everything is going to be affected, is it important to find out what started? The end is same, no?
Gray matter was affected as per history and eventually.
You get my question? White becomes also gray, starts with gray, also becomes white. Then what's the idea of trying to consider what started and what ended? Okay. And therefore important is, ultimately this will go on progressing. We have said it's a progressive neurological disorder. So whether it starts with white or gray, it will be everything affected. But we would know which kind of syndromes we are talking about. Primary white matter or also gray matter. So this is primary white matter or primary gray matter?
Gray matter
Gray
only.
matter, why do you say that?
First, the symptom was when mother noticed the social smile was not attained, then head control, then dystonia, cognition.
But apparently the story starts almost with tightness. Okay. Yeah, so.
But sir, if that was dystonia, then it is still gray matter.
Yeah, correct.
And
so that's what I'm asking. Why dystonia?
correct.
You have said first 3-4 times a day, thereafter 15-20 times a day. I thought it was a myoclonus. Why should dystonia happen 3-4 times a day and then 20 times a day? Dystonia occurs when you stimulate the child. Okay.
It might be status Not current.
No, so see now here probably you, so basically we should just make it a habit to separate out a seizure from a dystonia. That is very important. And then of course, depending on the distribution, that's why I asked you which limbs are affected. So whether it's a focal motor seizure or a generalized seizure. So obviously you have to ask about the sensorium of the child, awareness of the child, which will help you differentiate. And dystonia, there will always be twisting movements which will accompany, which are very unusual for a seizure. In a seizure, you don't usually get twisting movements. So these are the differences that you will have to make out. Having said that, localization of both is gray matter only. So spasticity will give you a white matter localization. So if you get a persistent tightness of the lower limb or persistent difficulty in changing diapers, then that is a probable white matter problem. Probable.
Also kind of a shortcut sometimes in your presentation of milestones. What is the degree of affection in each domain? You have said that already. Can you repeat? Do you remember, right? What is most affected?
Social or
Social is more affected, right? So there itself, white matter possibility goes down because the social is affected more. Then it's more likely that the nuclei are going to be affected or the higher brain function is going to be affected. Whereas if it was motor, then still the debate would be on whether it is white matter or gray matter. Seizures are definitely towards gray matter, but not necessary that seizures should be there.
When there is bilateral spasticity like movements and you are not very sure whether it's dystonia spasticity, concentrate on the eyes of the child. You want to decide whether a seizure or no. Concurrent with the spasticity or dystonia, if this child has upward gaze or sideward gaze, which occurs momentarily, then it may favor a seizure. While the eyes are not very, so to say, commentable and there was only dystonia, then maybe that may be one point against seizure. Unless somebody has seen that, somebody's experienced it, it may be difficult. But a point for us to ask, because sometimes the eyes part is not forgotten by the patients.
Now further you are saying there is history of generalized stiffness of the body leading to difficulty in changing diapers, which has now decreased after exercise. So this probably represents spasticity. Okay. Okay, so now presently you said child at present opens hand spontaneously means what?
It's like he has lost the milestone. Currently, he has lost the milestone. Currently, just opens and closes the hand. That's
So he has lost what? Means
the
till what
bidextrous
were his
switch.
adaptive abilities? One, you said bidextrous approach. Then
Only till then he had attained till 5 months. Then he lost that also. Abhi is just opens hands spontaneously. Doesn't reach for objects.
okay.
Open spontaneously as a regression, that's causing the slight confusion here. So you can say whether if fisting had persisted,
Fisting is not there.
not persisted.
Then no social smile does not recognize mother. Here, what should you cross check or confirm? So when baby does not recognize mother, what else is involved besides cognition? Vision. So you'll have to double check whether it's because vision is affected or cognition is affected. So how will you check that?
That child is able to fixate eyes or not.
That is one thing, whether child is fixating. What else?
Fixes and follows.
Looks at you when called for.
Or touch, etc. So that is so in a isolated vision problem, these other things would be normal.
There's a bit of a catch here. If child is already 3, 4, 5 month old now losing milestones. So hearing milestone, if you take it into account, localization of sound comes around 3.5 to 4 months. So if you expect a child with a DQ of 3 months to find out where the sound has come, he or she can only locate sound in the same horizontal plane. If he has to look here, then that is the next step of milestone. Okay. So I take your point. What I think you are trying to say is, if mother calls out, the baby recognizes that voice. And how does the baby you shows recognition, if not smile, is by either opening the eyes, stop doing what he or she is doing, or tries to become searching movements in order to find where the mother is. So I was asking, what is Meniere's? Did you check?
Child is like she tells like थोड़ा startle response है.
Startle
चौक
response.
जाता है बच्चा सुनने में. That's it.
The startle was always there and did not disappear, because till 6 weeks startle is normal, right? We agree. Moro's startle is part of the Moro's kind of, right? The child goes, hands go out and then they come in front.
That
And the
more.
other startle is when there was no startle, or startle went away and now the child has started startle.
Just like blinking of eyes.
No, what you are doing is you are describing startle, but did you get what
No,
Tushar
no,
was
no,
saying?
no.
See, when you start off, a newborn baby startles, that is normal, till 6 weeks, as he said. The importance is, in a degenerative disease, you get a hyperacusis and a startle which comes back at an age when it is not supposed to be there. Exaggerated startle reflex. So we are asking whether
No,
there is any such
no,
thing.
not
Okay.
exactly.
Language, you are saying cooing is present. So, okay, so global developmental delay, but this is not delay, as you are saying, this is regression, right? And social is more than language, is more than motor. Okay. Come now, tell us the.
1 year, 8-month-old boy born out of third-degree consanguineous marriage with normal birth history and with positive family history, with history of regression of milestones, predominantly social, since 5 months of age, associated with query generalized dystonia from 5 months of age without seizures, is a case of neurodegenerative disorder, most likely involving predominantly gray matter followed by white matter to rule out neurometabolic disorder. At presentation, child was afebrile with heart rate of 128 beats per minute, RR of 30 cycles per minute. Peripheral pulses were well felt, saturation maintained, CRT less than 3 seconds, pallor was present. Head to toe examination wise, microcephaly was present. No neurocutaneous marker was seen, no dysmorphism in the face, or no other abnormal features. So, microcephaly was significant in head to toe examination. Otherwise, child weight of 6.1 kg, which was less than -3 standard deviation, height of 76 centimeter, between -3 and -2 standard deviation, head circumference of 41 centimeter, less than -3 standard deviation, mid-arm less than -3 standard deviation. Impression was severely acute malnourished with microcephaly. Systemic examination wise, CNS wise, child was awake.
Yeah.
No, sir. Child is in ward, currently on my desk. Posture wise, both upper limb were extended at elbow and wrist joint and hands pronated. Lower limb extension at hip and knee joint with adduction of bilateral lower limb. Cranial nerves examination wise, so first nerve couldn't be examined. Pupils bilateral equal reactive to light. Eye movements were present. Chewing present. There is no facial asymmetry. A child reacts to a loud sound and child is able to swallow. Gag reflex is present and tongue movements are also present. Tone is increased in all four limbs. Power of more than 3/5 in all four limbs. Reflex wise, knee and ankle in right and left lower limb were brisk and biceps, triceps were 2+. Plantars were extensor. For abdomen wise, soft, non-tender and no organomegaly. Respiratory system examination, ear entry bilateral, no dead sound. CVS, S1, S2 present, no murmurs. Diagnosis, 1 year, 8-month male child, case of neuroregression with dystonia, with microcephaly, with significant family history and consanguinity, likely neurodegenerative or neurometabolic disorder involving gray and white matter. Sir, fundus actually was like normal they had given, but abhi
There is a microcephaly, right? So it must be perinatal. Hallmark of CP is a microcephaly, isn't it? Microcephaly is an important part of the cerebral palsy.
anterior fontanelle.
So give a thought of this microcephaly where head circumference is 41.
So you got sir's question that shall we say that because this is microcephaly, this is actually a perinatal problem?
Perinatal is significant birth history was like not there.
That is one reason, but just looking at the head and looking at the size of 41 at this age, can you kind of argue more scientifically that this is not perinatal?
Imagine this was perinatal, then how would you expect the head circumference? Imagine that it was postnatal, then is 41 okay? Suppose it was prenatal or suppose it was perinatal, then the head circumference would have been normal at birth.
At birth it might
Yeah,
be normal.
because there was no prenatal problem. And therefore, it was, let us say it was a 28 week, no, 35. So I think head circumference would have been relative. Now let's say it's 33. And if 33 has become 41, it has increased by 9 centimeters. And mainly the increase occurs in the first year of life. So it has increased by maybe 7-8 centimeters in the first year of life. Is that okay with a perinatal damage? Or whether it suggests that the baby's hair circumference grew relatively well for first 3-4 months, and after that there has not been significant growth.
Yeah, it might be because from 5 months all the complaints started. So that time might be.
So maybe you want to think that if it was normal at birth and there after it has grown little
Yes.
better than for perinatal, that's what to say. Perinatal would have been 41, should have been worse. Do you want to say that? Difficult?
Like if it is significant birth history, then also the head circumference would have been affected.
I think what I wanted to stress was we could guess what time the brain stopped growing. And here 41 suggests that normal 41 would have been about 3-4 months. And therefore, it did not stop completely, but almost stopped completely. Okay, it's a period of fast growing of a brain. And therefore, this probably tells us that the whole problem started a little after birth, maybe at 2 months, maybe at 3 months. Okay. And I think that is important. That's what I wanted to bring. But why not compare it with the length? Simple. No? Your all parameters are small. He's a small child. The head is also small. Where is the problem? 72 or something. I don't recall. But 6.1 and 6.1 and 76. 76. 41 is all right. Yeah.
Still, it shouldn't be less than -3 standard deviation. No? Head circumference.
Sir's question is, can you compare head circumference with the length of the child to get an idea whether it's normal or no, irrespective of other things? Till what age?
2 years. 2 years. Still it will
Of
come
1
less
year.
than -2.
And I think sometimes the head and chest can be reasonably compared till about 18 months. But again, malnourished child, so multiple issues. So this is microcephaly, but the onset of disturbed brain growth seems to be not at birth and therefore not perinatal. That's the point I was making. What kind of neurometabolic, can you guess what kind of? I think when it comes to guessing like this, the common ones we should kind of rule out. By common ones, common out of the rare. So which typical situations in infancy, early infancy starts?
Some organic acidemias, glycogen, organic acidemias,
Okay.
glycogen storage
Hypoglycemia would have
disorders.
been an issue and seizure, etc. You are right. So you started thinking. But the common ones are PKU, then maybe MSUD.
urine.
So you could put some of the questions as negative to say that there is no color difference. Okay. So the examiner will ask you, what are you talking about? So we are talking about PKU or an abnormal
Body
smell
odor.
to the urine. So make a little more than what you have done is perfectly right. And none of us want to know clinically what neurometabolic. There is no doubt. But some typicality might be considered in favor of one over the other, right?
Any investigations have been done?
So, as we always say, think about common things. Amongst the rare things, treatable rare things should always be also considered. Okay. So, when you're talking about dystonia, then dopa responsive dystonia should be kept in mind, because that could present not exactly like this with microcephaly, etc. But you can have a child who looks like cerebral palsy with dystonia, but can be dopa responsive dystonia. And so, can we also say that? So let's ask other way around. We are already talking about preterm with SGA. So could there be a prenatal insult which has caused a baby to be born with a small head? We don't know the birth head circumference, and so the baby's birth circumference is this way. So there's a say, suppose there is a structural brain malformation, and then you will have a similar story, or what is not fitting into that? Something is not fitting into that. Regression of milestones. Excellent. Correct. So the first normalcy and then regression, or rather stoppage and regression. So that's not typical of a structural brain malformation. Also not in favor of intrauterine infection, because intrauterine infection also one can have small head, preterm child, SGA baby. And then subsequent milestones, there would be a lag in milestones from the beginning, and it will continue. Maybe progressive, may not be progressive, but not regressive.
I was just going to mention that dopa responsive dystonia is not a continuous dystonia to start with. It may come only in the morning, thereafter there is no dystonia. So take a note. After all, what we are trying to say is, if this child came with dystonia to you first time at 3 months, then that was a treatable condition. Here, as he said, that the whole progress is out of question. But what he made a point was, on the first day when the patient came only with dystonia, you possibly not miss a treatable condition.
Investigation by CBC, total counts of 6K. CBC total counts 6,000, hemoglobin of 9 gram per deciliter, hematocrit 31.6, platelet of 2.19 lakh. RFT wise 8 and 0.6, serum electrolytes 136 and 3, PTNR was 18.3 and 1.52. Total CPK was rise 294, serum calcium of 8.2, and left device total bilirubin 0.4.
What you would have wanted on this first slide, which other investigation would you have wanted? Ammonia, okay. But usually ammonia doesn't present like this. Acidosis, no? We are all talking about
VBGS.
acidemias. So yeah, acid, pH and acid, and then think about which acid. So lactate also. And sugars.
Yeah, sugar. I think what he's trying to say is that when you are talking about the investigations, this is all right. In fact, I would have asked you why LFT and all that. That means, are you looking at metabolic, neurometabolic disorder which affects the liver, etc.? Not probably this. But then the order of things, you could say that routine investigations probably are not likely to guide me. So that if some examiner said, no, CBC is almost for everybody. So it takes care of it, but that does not give you any further inputs of what it is. And in that case, what you made a point is ammonia and sugar are the screening tests, acidosis. Okay. For every neurometabolic, these are the screening tests.
CBTSC wise pH of 7.42, PCO2 25.8, PO2 127, and bicarb of 16.4. This was MRI brain. It was done in 2020. It was normal findings. Like BESC only, benign enlargement of subarachnoid space was given. This was at the age of 6 months. Child is currently 1 year, 8 months. EEG was also done, which was also normal. Karyotyping was also sent of the child, which was also normal. And then NGS, actually this is brother's NGS, affected chromosome.
The older child.
3. Yes, sir, older child. Chromosome 3, variant of tyrosine 386, they are given. Is autosomal recessive inheritance. And parental carrier testing was advised. It was actually sent in BTD mutation has come, but both parents are normal. Child's report is at awaited. NGS has been sent.
Is that conclusion?
Hmm?
Is there anything?
In the older child, they have shown a likely pathogenic mutation. Parents are tested normal. So that's a problem. Here it's means heterozygous. So 1 point mutation, and this child's report is awaited. It's not inherited in that sense, though there is consanguinity.
BTD mutation. BTD mutation करके उनका भी they had like got the report NGS, but they are like normal, like उनका कुछ neuro CNS wise history
मतलब
नहीं है, only symptoms. Both are affected.
Parents will not, suppose you are thinking about autosomal recessive, parents are not going to have, unless they have either double heterozygous or anything, which obviously is not there clinically also. So if both parents, basically, if this first one you are showing here as VUS, right? Variant of uncertain significance. The second one you have written likely pathogenic, the PVS1 or PM2. I don't understand that. But at least heterozygous. But so even that should not really cause a problem unless these two together have some issue. And this fits with the previous child's phenotype, means complaints.
The second child report also through like telephonically they had told like first children ka jo tha same
Same,
report
ma'am.
is there.
Just playing devil's advocate here. Okay. Suppose you have this report and you have a second child who is born with has similar complaints. Would you do an MRI? You are paying, okay? Patient's not paying. So anyway, always somebody is paying. Remember that. So whether you do an EEG, whether you do an MRI, or whether you do just the NGS, get the diagnosis and say, this is it, and I'm not going to do anything else. My point is, if you know the diagnosis, I'm putting it otherwise, you know most likely diagnosis is this, whether you would need to do all the other investigation or not. It's a trick question.
No. Well, the required investigations would be not all.
No, NGS we are doing. I'm not saying no for NGS. You have to prove that this is this. You did NGS, you got it positive. Would you do MRI? Would you do EEG? That is what I'm asking. To simplify and ask you the question, why do you do EEG and why do you do MRI in this patient? See, NGS may show the same mutation. That does not necessarily mean that phenotype will be exactly same. And so EEG may be required in order to treat, not treat, etc. So it's always good to have a full investigation done for these patients. I mean, technically if you get MRI changes, you have an NGS in the previous child, you get a similar MRI image, I may not do, if there is no treatment, I may not do an NGS again and accept that this is it, provided parents are carriers and things like that.
Green light ऊपर रखो। आपके तरफ रखो।
Yes, when I passed my MBBS, I took I'll do to my child. Then, but we forget it because we talk. It is in Latin and Greek, and we don't know whenever we took it, and it never is practiced. Then we don't ask economic history. What is the family earns? So most of my colleagues, thousands of rupees for a family which doesn't earn 15,000 rupees a month because they have forgotten the worth. So when I see a child has MRCP, I can't do anything. We still continue order because we want to document it. I mean, whatever our learning, trainings are, our learnings are. But primarily we have forgotten to be humans and forgotten our oaths. So I think, so we have translated it into Marathi and Hindi simple and put it on the wall and share it with every doctor who comes to us. Put it on your wall and read it before you start your practice. So that puts everything in perspective.
I think it's important to counsel the parents. The test must be done because we want a final diagnosis. It could be of some use for the next pregnancy. Okay. So if we counsel correctly and say that we plan to do some tests and those tests should be useful either to this child or at least to the next child. Okay. Which means that for this child it may not be useful, but even then, why do you want an EEG? We might need even an anti-epileptic drug at times. Though EEG alone should not, because there is no clinical matter, but that's why EEG would be important. Similarly, the MRI, he gave a good reason that next child's MRI is same, then no need of a large number of further tests. So I understand what Hemant said about economics, etc. But I think in medical practice, let all be decided by the parents after giving them right information. And what is the right information? If I do all this, what is your child's benefit or the family benefit? They must know that the benefit could be 2%. That means 90% nothing. But they can take a decision, no? Many times in India, they would ask, but sir, what you would have done? At which time now they are asking your opinion, and you must end up, whatever your opinion is, by saying that this is my view, but this is not the best and the right view. You have to decide yourself. And I think the decision, yes, would be many times. Earlier times when liver transplant itself had just come in, I remember when I was at Wadia, I would tell them, don't much discuss about all this. So they said, no, but we'll have to discuss. I said, yes, but discuss in a manner. And that time, the CM of Maharashtra had gone to Chennai for a liver transplant and never came out. So I said, this is a good time to say, liver transplant is possible, but did you know that CM of Maharashtra had to go there, but that it was not successful. So spending money, etc., may not guarantee success. But yes, there is one another way of treatment. So I think the philosophy is you must leave it to the parents to decide. You may help them to take decision, but even then you should not thrust upon your view onto them. Because at the end of that, they want to do the best for their child, whether useful or not. Right?
Good evening, everyone. Today, Mhm. Today I'll be presenting the short case for today's clinic. A 2.5-year-old male child. Am I audible? A two and a half year.
Very well
You are
audible.
audible. You are audible.
A 2.5-year male child, first by birth order, out of non-consanguineous marriage, resident of Latur, Hindu by religion, brought by mother, came with chief complaints of fever since 3 days, increased work of breathing since 1 day, and lethargy since 1 day. Fever was low to moderate grade, intermittent in duration, relieved on medications, and child was active in interfebrile period. Increased work of breathing was noted in form of tachypnea, subcostal and intracostal retractions. Lethargy was in view of child preferring to sleep and drowsiness. Associated were the history of bluish discoloration of finger, nails, lips, and toes seen since 3 months of age. There was no history of rash or ear discharge, no history of cough and cold, no history of decreased oral intake, decreased urine output, and no history of bottle feeding. Patient was admitted from 16th May to 22 May outside in an outside hospital and was diagnosed as congenital heart disease with severe bronchopneumonia with severe respiratory distress. He had received injection of ceftriaxone and amikacin. 2D echo was done, which was suggestive of large restrictive VSD and other manifestations of complex congenital heart disease. In ANC history otherwise uneventful, but during second trimester ANC scan, a diagnosis of congenital heart disease was made and it was explained to the parents as well. Birth history, there was history of the child has been delivered by LSCS. The further details are not available for that. There was history of neonatal jaundice at day of life 3 and history of NICU stay for 15 days. Developmental history, there is a delay in reaching developmental milestones. Currently, gross motor child stands with support fine DQ of developmental quotient of 34%, fine with fine motor radial palmar grasp, developmental quotient of 29%. Social milestone reached is cooperates while dressing, which has a development quotient of 38% and language 5 to 6 vocabulary words with a developmental quotient of 51%. Overall impression, bowel bladder control also is not achieved. Overall impression, there is gross developmental delay. Immunization history, immunized child is immunized till date. Diet history, mixed diet, and child eats from the same family pot. Socioeconomic history belongs to lower socioeconomic class as per modified Kuppuswamy socioeconomic scale. And family history is not significant. So, to sum,
Milestones which you have given the developmental history. The development you have given, just go to that.
ठीक है पहले एक डिस्कस करूं then we'll come.
Mine is also battery.
Yeah, so now this 2.5-year-old fever since 3 days, increased work of breathing since 1 day, and lethargy since 1 day. So based on this history, what do you expect?
LRTI.
Yeah, so LRTI is a term that we residents commonly use, but basically bacterial infection or viral infection, and which anatomical part is most likely it is affecting.
Bronchopneumonia, most probably of viral origin,
Why do you say that?
because it is more common in children. Children viral, it is more common.
So suppose I ask you the other way around. Tell me the classic history of a viral infection. What history will you give?
Prodrome history of fever, cough and cold, coryza.
So where is the cough and cold?
It was not in
So then why viral? Cough and cold is a very, very strong part of a viral, no, any viral. So if there is no cold and cough, then you have to think again whether it's viral. Okay. Then why bronchopneumonia?
because lobar won't lead to significant increased work of breathing. Overall, overall bronchial anatomy would be affected, leading to significant increased work of breathing. Lobar pneumonia can be compensated by other the rest of the functioning lung.
Okay, so good you brought this out. So this is worth discussing. So arbitrarily, one lobe of the lung, lobar pneumonia we're talking of. So one lobe of the lung, whichever lobe you take, of course the lower lobe is huge, but arbitrarily any one lobe is how much percent of the lung? Just arbitrarily. 10 to 15% at least. Now suddenly if 15% of the function of the lung is gone, the keyword is suddenly. It is like suddenly losing 15% of your blood volume. What happens? You go in shock. So sudden or acute dysfunction of 15% of the lung will lead to hypoxia and therefore tachypnea and increased work of breathing. So what I'm trying to say is that your statement that one lobe of the lung gone wouldn't become breathless is not right, would become breathless, right? Because it is acute and sudden. On the other side, any bronchial pathology, what is the hallmark symptom? Cough. So if we talk of, first of all, we'll discuss bronchopneumonia. Last time, Tushar said that in Nelson also there is no word like bronchopneumonia. But bronchial involvement must give you a cough. So I get your point that you get young children who come with fever, cough, and breathlessness. The timetable is that their cough and breathlessness is soon after the fever, and they are probably reactive airway disease where their airways are involved. due to a viral infection, and they get fever, cough, and breathlessness. But when there is, if this history is correct and there is increased work of breathing after approx 48 hours of the onset of fever, it's a classic history of a lobar pneumonia, right?
I think cough is a must for a respiratory problem. Okay. Acute respiratory problem. Chronic interstitial lung disease may not have cough as a predominant feature, but acute, yes. May not be severe cough, but at least mild cough. Same is also pneumonia also. So that is number one. Second is, when you get breathless like this, first response of the brain is irritability and not lethargy. Okay. Look at the bronchiolitis. Typically, one day fever, next day breathless. But what kind of breathlessness? He's crying all the time. The nature wants him to take more breath and improve oxygenation as if. Here is the lethargy. So this suggests that this child has developed hypoxia. Now, how can he develop hypoxia all of a sudden? That means the hypoxia must have been earlier also. And what kind of hypoxia earlier means? You're talking about a cyanotic heart disease. So I think absence of cough is a strong parameter in an acute onset disorder. Chronic, slowly progressive disorder over weeks might not have a cough to some extent, like chronic bronchiolitis. It's not chronic bronchiolitis, but something like bronchiolitis going on for a long time. Okay, that may not have a cough as a predominant feature. You have a breathlessness. Okay, you have a lethargy. You have a hypoxia.
History of fever would rule out.
Fine. So there is no reason for fever. Okay, but anything more than that?
He has complaints of bluish discoloration. PG complaints.
I think methemoglobinemia has a wide spectrum. Some of them may be asymptomatic or a minimally symptomatic, and therefore they come often with exertional dyspnea, okay, breathlessness, but not an acute onset like this. So possibly this is a cyanotic heart till proved otherwise. Okay. And why should cyanotic heart get fever?
In case of, if it gets complicated with infection, it could have fever.
What complication of cyanotic heart gets fever? Brain abscess, you think?
No, sir. Pneumonia.
So fever is not a common feature. Okay, but it could be coincidental. That is fine. But fever is not a common feature for a cyanotic heart disease.
You want to be a bit careful to say pneumonia with cyanotic heart disease, because the common cyanotic heart disease which you see at 2.5 years, which have not required treatment, are going to have low
Blood flow.
to the lungs, right? Lower blood flow, not increased left to right shunts. So they don't typically come with pneumonias or lobar consolidations.
So now if you look at this story, so see, I again understand that we are still learning, our histories and all may not be perfect and we may not get the most accurate history, but at least we are learning. So now what does the first line about fever suggest?
Low to moderate grade.
Just tell us the interpretation of what.
Viral infection or bacterial?
Viral
Infection. What does the second line suggest? Increased work of breathing in the form of tachypnea, subcostal retractions, and intercostal retractions. So what does that suggest?
Viral.
So, but parenchymal has to be unilateral or bilateral?
Violent.
Not necessarily means parenchymal. When we say it is usually lobar, it is usually unilateral. In fact, bilateral would suggest a airway disease more than a parenchymal disease, the way you were originally saying that this is a viral infection. So these are small things. There could be some errors in what history we are getting. And then lethargy also has to be dissected properly. Okay, till what point was the child active, till when did the child become lethargic, etc. Right? Okay. Now,
On history, I'm not really sure whether one should be commenting on SCR,
retractions and all,
ICR,
correct?
subcontinental intercostal. It's very difficult even on examination because many times you will have both the things. Okay, so that's another additional point.
And I think in typical asthma, you don't have an intercostal retraction. Typical pneumonia, you don't have a subcostal retraction. So when you have both of them, it indicates almost that the pathology has also caused airway plus some lung parenchyma. That's what earlier used to call bronchopneumonia. And that kind of a thing makes us again feel whether it's some cardiac event. But as he said, that history cannot make out. And on examination, you might be able to.
So now coming to this term of bronchopneumonia. So actually, this is often used by our investigation colleagues. So our radiologists often use this terminology. And whenever you have a bilateral significant respiratory distress, this terminology is used. Now, here again, 2D echo was done suggestive of large, and this 16.5 to 22.5, that means some last year. And presently, it is just these 3 days of issue. Yeah, okay.
So this is not a cyanotic heart at all. It's a VSD.
That's what I was coming to next.
So we have all gone astray, isn't it? Now this is more reliable than our brain talking something. Okay, so what do you think? This must be right?
Might be associated with LRTI with VS.
So what I meant was that this kind of VSD doesn't cause cyanosis. In fact, should have had caused cough, probably. Okay.
You
But
agree to
history is
that,
clear.
na? A large restrictive VSD is a acyanotic heart disease. You agree to that? So now, if the
So
cyanosis,
is it VSD a cyanotic heart disease? Then why are you saying it's cyanotic heart disease?
Cyanosis, bluish discolor, history of bluish discoloration
is there since 3 months.
is there since 3 months of age. And
So when does VSD have cyanosis?
That's the question.
When there is Eisenmengerization. Okay, but this is there from 3 months of age.
No, the cyanosis is
Yeah,
there
very
from
good.
3.
Say it. Associated with other pathology, or as not forget the large restrictive, but VSD, as we know, is a overriding of aorta and pulmonary stenosis, and the whole combination is your fellow's physiology or similar. So isolated VSD, acyanotic. Eisenmengerization, cyanotic, or VSD with some other congenital heart disease.
Sir, now you wanted to talk about milestones.
I just wanted to say that you have written stands with support. Now, what question have you asked? Is he standing with support now? Did this what you asked? For example, language 5 to 6 vocabulary. Does he do it now? Now he's now, let us say 1 year and 1 year and तो अभी बात करता है क्या करता है 5-6 वर्ड बोलता है क्या? बोलता है. Current milestone.
And then the previously achieved milestone.
So at what age he achieved is important for finding out the DQ. He started, let us say, in language 5 to 6 vocabulary, he may have started much earlier. And then his DQ for speech is much better. So आज खड़ा रहता है तो वो तो एक साल में भी खड़ा रहता है. Today is 3 years. So if you say that 3 years खड़ा रहता है and find out the DQ, that's not right. So you just make sure that ये कब करने लगा. So the age at which he has achieved and age at which he should have achieved is what should compare. Because having achieved that milestone, he is going to continue with that milestone.
Also,
Have you seen cyanotic heart with a delayed development? You have several delayed development, you have nothing in the heart. And when you see cyanotic heart, whatever kind of cyanotic heart, okay, you see the delayed development. Does cyanosis cause delayed development? Your answer is no, no?
It can be associated, may or may not be associated. See,
means associated in the sense.
means it is a finding, but not related to exactly the pathophysiology of cyanosis.
Correct. So then what is the cause of the delay?
As it was antenatally diagnosed, it could be the impairment of circulation in intrauterine life.
No. So that's also related, no? So
we'll
no,
make
that's
you
not-
make a quiz question. Congenital heart, a VSD with early Eisen mineralization and delayed milestones. Which condition do you think of and why? Which condition gives rise to early Eisen mineralization? That's the simpler question. Why does Eisen mineralization occur?
Shunt reverse.
Why does shunt reverse?
TV1.
Okay.
Due to pulmonary artery hypertension.
Correct. Or pulmonary vascular hypertension leading to pulmonary artery hypertension. So which condition you have early increase in pulmonary vascular hypertension?
Tricuspid.
Down syndrome.
No.
Let's not waste time. So when you have some such situation, one escape route in the exam would be something like a Down syndrome where you have early cyanosis because if it was only isolated VSD and now you have symptoms suggestive of that. And then you can have delayed milestones. But here Rajesh is asking a different question.
I think in every heart disease, you must look for syndromic combinations. And typically VSD, simple VSD also has a multiple areas of involvement. And therefore, this is a syndromic problem, whatever the syndrome.
So I'm in fact agreeing to what you said that usually just cyanotic heart disease does not cause so much delay. That's what sir also is saying. So first is question yourself whether it is that delayed. And if it is really that delayed, then syndromic association, Downs or whatever, right? Otherwise, maybe our history or our assessment is wrong. Okay.
Gross motor can be delayed because of poor
That's
oxygenation.
also
to
slight
appetite.
delay. Slight
But-
delay. Huh?
Yeah.
But again, not so much.
Exactly, not so much. Okay, and it won't be global, right? Okay. No, come.
On examination findings, the child was afebrile with irritable and initially irritable and a heart rate of 142 per minute and respiratory rate was of 60 per minute with ICR and SCR. Peripheral pulses were bounding, extremities were warm, saturation was 50 to 60% on room air with pallor present, cyanosis of bilateral fingertips and toes and lips and bilateral clubbing was there. Upon anthro, weight and height length fell under less than -3 standard deviations. Head circumference was between -3 to -2 standard deviation, and mid upper arm circumference was less than -3 standard deviation. So weight for height was less than -3 standard deviation. Impression anthro-wise was SAM. Systemic examination was showed tachypnea, bilateral SCR and ICR, central trachea, air entry bilaterally equal with left-sided clefts present in mammary area. CVS S1, S2, and there was a tachycardic murmur with apical impulse and parasternal heave. CNS tone, power, and reflexes were normal. Per abdomen soft, non-tender. Liver was palpable till 5 centimeter and no organomegaly. So to conclude,
What is tachycardic murmur?
Some of the findings we are not sure what you mean. So okay, go to the okay. One sec. You said peripheral pulses are bounding.
Yes.
And blood pressure, yeah.
Severe pallor and also jaundice. Also the cyanotic.
Exactly. So can you make out pallor in the presence of cyanosis or vice versa? So what are the issues?
I'm looking at palms, but if it's severe pallor, we might look at conjunctiva. That might help. Otherwise, bluish discoloration would affect pallor recognition.
So whenever a patient is actually cyanotic, it is difficult to appreciate pallor. Most cyanotics look plethoric and therefore it's further difficult to look at pallor. So investigation wise, they may have relatively lower hemoglobin, which you will find on investigation, and relatively less iron. The other way around, you need at least 5 grams of reduced hemoglobin to appreciate cyanosis clinically. So in severe pallor, if there is not so much of reduced hemoglobin, you will not appreciate cyanosis in a severe pallor. So that's the relationship between pallor and cyanosis. So whenever you say both, you have to be a little careful. Okay. Secondly,
I thought severe pallor is the cause, right?
Yes.
But it's not. Because cyanosis is also there.
have you taken the BP by non-invasive or anything? No. Okay. So the bounding pulse is a bit of a, it raises our antenna whether it's really bounding or no. So that is one. Then go ahead. Okay, go ahead.
There is some myotubular communication, almost like a patent ductus.
Yeah.
So
AV malformation or whatever. Now,
If you have, statics, or if you have TOF with severe anemia and impending failure, only then you can think about that too, not bounding pulses, but tachycardia and increased pulse pressure.
that is what is called tachycardic murmur. No, I will not.
so what did you mean by this word tachycardic murmur?
means
Achha, you have.
the heart rate was raised and consecutive there was a murmur, but I couldn't make out whether it was a pansystolic murmur or an ejection murmur. It was there present along with tachycardia.
Correct. So don't call it tachycardic murmur. You say tachycardia is present and there is a murmur. And as you rightly said, I am not able to make out details of the murmur. Okay. So don't call it a tachycardic murmur. Now, apical impulse plus means what did you mean? The patient is not here.
No, patient is actually on NI.
Okay. So when you say apical impulse plus means, what did you want to say? It is visible, it is palpable, or
Palpable.
okay. So you'll have to say where is it? It is in the fourth space, fifth space, inside
Yes.
mid-clavicular, outside mid-clavicular.
Fifth space inside mid-clavicular. Fifth space inside mid-clavicular line it was.
Okay.
Is
Fine.
it tapping, heaving, hyperdynamic?
No, actually I didn't understand that.
Fine. And parasternal heave is present,
Hmm.
right?
Hmm.
Okay. What does that mean?
Increasing volume overload would be
No.
Right side hypertrophy.
So you've got right ventricular hypertrophy definitely as one finding if parasternal heave is present, right? Now, what could that be due to? So you have to analyze all the rest of the things. So, what could that right ventricular hypertrophy be due to? What are the common causes of right ventricular hypertrophy? Practically, I don't want the list. I want only one or two causes. One is pulmonary hypertension, right? So we were discussing whether this is VSD with Eisenmengerization. We said that if cyanosis is since age 3 months, that is very unlikely. But we are still again looking at the findings. So if this is pulmonary hypertension, what other findings should be there?
This one is 2 plus.
S2 should be loud and palpable. Okay, if it is pulmonary hypertension. What else can cause a parasternal heave?
volume overload.
So right ventricle rarely gets into volume overload. It gets into pressure overload.
Pressure.
When is that it gets into pressure overload?
Pulmonic stenosis.
So better word is outflow tract obstruction. You're right, pulmonary stenosis, but classic pulmonary stenosis, is it a cyanotic heart disease or a acyanotic?
Acyanotic.
Acyanotic. Here you're talking of cyanosis. So if at all you're talking of Fallot's situation, so you'll say outflow tract obstruction. So it could be that this is due to outflow tract obstruction. Now there, what about the heart sounds?
Loud.
Absent. So in most cyanotic heart diseases, the S2 will be either very poor or nearly absent. Okay. So this is the big difference. Pulmonary hypertension, loud and palpable S2. Cyanotic heart disease, S2 absent. Okay. Now, sir is asking tricuspid regurg. Okay, it's rare. What else?
Won't lead to hypertrophy. It won't lead to hypertrophy. It would be more of dilatation.
Okay. Yeah. Okay.
There should be pulmonary hypertension to cause tricuspid regurgitation due to backflow.
So what you are talking of is ulta. See, in many situations, once the RV gets very enlarged, as a result, there is tricuspid regurgitation, which is picked up usually on the echoes and all, as a effect of the enlargement.
I think tricuspid regurgitation is not a pathological thing, but maybe functional. And often the echo would say, yes, there is some also trifid, but that doesn't present with a heave and so on.
So I'm just revising very simple things, how to correlate findings. So now he said apex is in the midclavicular line in the fifth intercostal space. So now tell me, based on these findings, will you still entertain a diagnosis of VSD with Eysen-Mengerization?
What does this finding tell you? What does this finding tell you? Which enlarge? What is enlarging? Left ventricle is not enlarging, or is it enlarging?
Not enlarging. So that goes in favor of VSD or against VSD?
It goes in favor of VST.
Why?
Because because of mixing shunting.
See, you have to go through the natural history. So a large VSD at the beginning will have what? Volume overload or pressure overload? When it starts, a large VSD,
Volume
first month,
overload.
second month. Volume overload. Which ventricle? Left ventricle. So left ventricle volume overload right from the beginning. So left ventricle is going to get enlarged. Okay. So the apex is going to be down outside the midclavicular line and it's going to be hyperdynamic. Then over time it develops pulmonary hypertension and then reverses, and then the right ventricle also comes in. So typically you would have biventricular hypertrophy, but absent left ventricle is totally throws out the diagnosis of VSD.
But I thought VSD has two outlets, one aorta and one VSD. So why should there be volume overload in the left ventricle? Volume is going out. Volume is going out. Now, what is the problem?
It has to pump more blood than usual.
Comes back
Back
to the
to
pulmonary
pulmonary
circulation. So first cycle.
Okay. Now, just for learning sake, again, the respiratory findings, if it is your Krebs are only in a localized area, then this could still fit in with a pulmonary, local pulmonary issue. However, that original point which Tushar made, that we are talking of a low blood flow setting, so think carefully and all that. So that is important.
And just to add on to that, in real life, it does not mean that child with a TOF cannot get a pneumonia. Like any other child can get pneumonia, child with TOF also can get a pneumonia. It's just that what we are trying to say is that they are not predisposed to getting it, like a left to right situation.
Now, 5 centimeters liver. So what does that mean? Right-sided failure. No, so other option is right-sided failure there. It's actually enlarged and congested. So right-sided failure. Along with that, you have.
See the JVP, then you will be able to make.
Yeah. So if it is a Fallow's physiology, then and failure, then it is that situation where either there is severe anemia or there are lot of collaterals. Again, that doesn't fit in with a cyanosis which started at 3 months of age. So a little bit of inconsistencies. Go on. Click on this with your cursor and then this side only you click.
Just press arrow.
Sure, yeah.
To conclude, a 2.5-year male child, first by birth order, born out of non-consanguineous marriage, came with complaints of fever, increased work of breathing, and lethargy, with previous history of LRTI and ANC history, as well as 2D echo suggestive of complex congenital heart disease, with examination finding of cyanosis, cardiac murmur, Krebs, increased liver size is suggestive of congenital disease, which is cyanotic, that includes TOF, TGA, TAPVC, tricuspid atria, and truncus arteriosus.
So why these 5 DDs?
They fit into the cyanotic category.
Okay.
VSD comes as a part of TOF.
Part of top, agreed. But what about the other? You have an echo report which says yes. Report can be done.
So I think many of them are part of the top physiology, and you have to complete it by saying, so listen, you're auto checking.
No, report. No.
We are not questioning that, yaar.
No, we are not questioning the report.
We are
What we are saying is that if
teaching you
write-
something.
If you're writing top physiology, then along with top, when you write VSD with PS and so on and so forth, rather than writing only PTA.
So when we use the word top physiology, what does it mean? Correct. That is the tetralogy of Fallow. But in that tetralogy of Fallow, which are the important or the topmost things which also fit into top physiology? You understood what I am saying? So suppose your tetralogy of Fallow, one component is right ventricular hypertrophy. Okay. So suppose some other lesion has right ventricular hypertrophy. Can we say that is top physiology? No. So what is the most important part which we say which is giving rise to top physiology?
Pulmonary stenosis.
So again, use the word outflow tract obstruction. That is one. Second, exactly. Right to left shunt. So that VSD. So now again, suppose you have just a VSD, a muscular VSD, standard VSD, and you have a PS. Okay, valvular PS. This combination, VSD with PS, is it a cyanotic heart disease? No, it's not. Because the shunt is not there. The right to left shunt is not there. Right? Because this VSD does not cause so much of equalization of pressures. There is still a lot of pressure gradient. So maybe at a very extreme pressures of pulmonary stenosis, it may happen, but otherwise it doesn't. So what I'm trying to say is in that top physiology, like you said, outflow tract obstruction and right to left shunting are most important. So coming to this list, can only TGA be a diagnosis in this child? No. Why?
No shunting and no outflow.
So only TGA is deep cyanosis right from birth because there are two parallel circulations, right? So cyanosis comes very early. Here it came at 3 months. But if you make it TGA with VSD with PS, then it becomes a top physiology. Okay. So similarly, the others, so truncus arteriosus, VSD, PS, these are all parts of that top physiology. Understood? So you're in exam, instead of giving all these diagnoses, you just say clinically top physiology, most likely tetralogy of Fallow, but could be any of the others.
Yeah, I think in a typical situation of overriding of aorta, two other extremes can happen. Both outlets could be from the same ventricle, that is double outlet right ventricle, or there could be total transposition. So they are all part of Fallow's physiology. Could there be something more? So when you say Fallow's physiology, tetralogy is one, TGA with VSD with PS another, double aortic ventricle with PS is another.
Sir, one
Where?
second. At the, as sir explained, that double outlet right ventricle is where that overriding has become so much that both are from that one ventricle. Now take it in the ventricular form. If you take this same problem in the ventricular form, it can be so much that it is a single ventricle. So single ventricle VSD PS, double outlet right ventricle VSD PS. These are all variations of that overriding of aorta, right? Sorry, sir.
So tricuspid atresia looks different. That's a left ventricle and not right ventricle.
What was the
What is the echo like?
So, 2D echo was suggestive of congenital heart disease with query tricuspid atresia, large VSD, and severe pulmonary stenosis. Mixed overall mixed physiology was seen. RV LV dilated, RV mildly hypoplastic, and large non-restrictive VSD was seen with large OSASD and right to left shunt.
OSASD also?
Yes.
Tricuspid atresia means it has to then come in from somewhere.
And pulmonary artery was hypoplastic with right ventricular outflow tract obstruction, and that's these were the other findings.
Fine. So we've said this many times that in the exam you are not expected to give the actual diagnosis or the echo diagnosis. Your basic concept should be clear. So in the exam you should be able to argue why this is not VSD with Eisenmengerization, why this is a primary cyanotic heart disease, that you have to argue, and you have to understand what is Toff's physiology. Right? That much if you would say in the exam, it is more than enough. Right? Okay. Okay, chal, we'll stop here. Yeah, Anjali, you could hear everything. Anjali or Pallavi, who was there?
It was
Yes, sir.
very
Yes,
clear
sir.
throughout, Rajesh.
Yes,
Sorry?
sir.
Today was excellent.
Okay, okay.
Audio
Chal.
was very good.
Yeah.
Yeah.
Thanks.
Thank
Thanks.
you, sir.
Chal.
Thank you,
Bye.
Rajesh. Thank you,
Thanks.
everyone.
Bye. Bye.
Thank you.
Okay,
Bye.
bye.
Bye.